Thank you very much, Dr. Gottesman. I wish to congratulate the organizers for putting together this fine meeting. I think it's an honor for Israel to be able to bring such great speakers from abroad and to put together such a great program. I've been asked to give an update on the role of intra-aortic balloon pump in acute heart failure, and I will concentrate on the topic in acute heart failure where intra-aortic balloon pump counterpulsation is more pertinent, which is cardiogenic shock. So let's see what we know about intra-aortic balloon pump. First of all, it's over 50 years old. In 1962, the first animal studies were done, and the results were published in the American Heart Journal in 1962, showing that it is an effective way of augmenting cardiovascular status. In 1968, we're talking almost 50 years ago, that was the first clinical description of the use of intra-aortic balloon pump in the setting of shock, and this was in JAMA. In 1973, the first report, registry of shock, remember the first patient was in 1968 reported. By 1973, the first registry of shock and intra-aortic balloon counterpulsation was published in the New England Journal of Medicine. And 40 years after the introduction of intra-aortic balloon counterpulsation, there were more than 1 million patients who had received this therapy, and this was published in JACC, and we'll show the results also, just to give you a background. So this is the New England Journal of Medicine in 1973, 5 years after the first patient that was treated with cardiogenic shock was published in JAMA. And here they showed the results of 87 patients who were treated with intra-aortic balloon pump for cardiogenic shock. 52 of these patients died. That was 60%. At that time, the expected death rate for cardiogenic shock was 85%. However, the authors need to be commended because even at that time, when the results were quite impressive relative to their expectations, they still said that you cannot say anything about the effect of intra-aortic balloon pump on survival. So even around 40 years ago, they knew that the issue of survival was not a trivial issue. And this is the benchmark registry in 2001 in JACC by Ferguson and the co-authors that summarized the experience at that time. It was over 4 years in 203 hospitals, 90% in the US, around 17,000 patients, and we see that the indications for intra-aortic balloon pump were hemodynamic support during or after cath were in 20% at that time. Cardiogenic shock was only 19%, and then there were the other results. The complications at that time, and I have to remind maybe the younger people in the audience, at that time we're talking about a very bulky system, a 10 French or 11 French system, which is not the same systems that we use today, which are 7 or 8 French. But at that time, in 2001, the results showed that the major complications occurred in 2.6% of the cases. In-hospital mortality was 20% in all patients on intra-aortic balloon pump, and the predictors of complications at that time were female gender, higher age, and PVD. So that's what we knew by that time. And why would we want to use an intra-aortic balloon pump for cardiogenic shock? First of all, because it reduces afterload. It increases diastolic coronary perfusion pressure. It modestly increases coronary blood flow. One of the things that we have to remember, which is something which is a misconception, intra-aortic balloon pump has a minimal effect on cardiac output. It does not increase cardiac output in a significant manner. It has currently an excellent safety profile. In the current mode that we use it's easy to use, and it can help stabilize the patient in cardiogenic shock while we administer other modes of therapy. And here we see a summary of the use of intra-aortic balloon pump in cardiogenic shock. We see several registries, and one of the co-chairmen today, Dr. Yakovshvili, reported the experience from the EuroHeart survey around 10 years ago. That was an ACS registry showing that in cardiogenic shock, only 25% of patients in cardiogenic shock received intra-aortic balloon pump at that time, although it was a class 1 indication. And one of the reasons this paper was published was to show that there was underuse of intra-aortic balloon pump at that time. By the way, in all the papers from Gusto 3, Euro Heart Survey, they showed that among those patients who had received an intra-aortic balloon pump, there was always a trend or a significant improvement in survival, but this was a retrospective analysis of a cohort. And then we have the shock registry, which was published in the late 1990s. And again, this was in centers that were minded for shock, and there the use of intra-aortic balloon pump was 50%. And in the shock trial, it was almost felt unethical not to use an intra-aortic balloon pump, and actually it was used in around 90% of the patients. So all these studies suggest that maybe there was an underuse of intra-aortic balloon pump, and that maybe there isn't a survival advantage, although there was never a prospective randomized study that showed this. I just want to go over with you the shock trial because I think it's pertinent and it's important to understand the results of the subsequent studies that I will describe. The shock trial was a trial that randomized patients to either emergency revascularization within 6 hours of randomization, and intra-aortic balloon pump was recommended in all patients, versus initial medical stabilization, and again, intra-aortic balloon pump was indicated in all patients. And that is why around 90% of the patients in the shock trial received an intra-aortic balloon pump. And there was also a shock registry, which included all the patients who had exclusion criteria and thus were not included in the shock trial. I think it's important to show that it took over 4 years to enroll the patients in the shock trial. And at the end of the day, we're talking about, when we talk about the shock trial, 302 patients who tell us what to do in shock in terms of revascularization. 152 that were assigned to revascularization, and 150 that were assigned to medical therapy. And again, the shock trial included only patients with STEMI or new left bundle branch. It did not include patients with non-STEMI, and it's important when we will discuss the subsequent studies. And one of the things that people do not remember when we talk about the shock trial is that it was a negative study. When we talk about 30-day mortality, the p-value is 0.11, which is not significant. However, we were encouraged by the results of 6 months and 1 year, which showed a significant improvement. In addition, when we talk about 10 years afterwards, and we see that, and among hospital survivors, among all patients, there was also a trend or a significant trend in terms of survival. But again, when we talk about 30-day survival, the shock trial was a negative study. And you'll see why I'm emphasizing this soon. So, up to around 2012, 2013, intra-aortic balloon counterpulsation was a class 1 indication for cardiogenic shock. Based on the ESC guidance, it was a 1C. Based on the American guidance, it was 1B. What happened between 1C to 2B or 1B to 2A? The explanation to that is the intra-aortic balloon pump Shock-II trial. And the results of that caused a downgrading of the use of intra-aortic balloon counterpulsation and cardiogenic shock. However, I think it's imperative that we review this trial and try to understand the results. So what were the exclusion criteria? Shock beyond 12 hours. That is the same as the shock trial. Resuscitation greater than 30 minutes. That means that people who had undergone resuscitation for under 30 minutes were included in the shock trial. Mechanical complications, AR greater than grade 2, and age greater than 90. So who did they include? People with a systolic blood pressure of under 90, or those who received vasopressors and had signs of hyperperfusion. They took patients with acute MI, and in this case they took STEMI and non-STEMI patients who were considered to be in shock, who were planned to undergo PCI or CABG revascularization, and they were randomized to either intra-aortic balloon pump or no intra-aortic balloon pump. And again, the primary endpoint was 30-day mortality, the same as it was for the shock trial. Now, I think it's important that we go over this slide, although it's very busy, but I'll try to go over with you. There were 790 patients who were screened, and at the end of the day, there were 600 patients who were randomized. This is shown here. However, out of the patients who were randomized, which 300 randomized to intra-aortic balloon pump and 299 to control, we know that there was a crossover of 30 patients, that's 10% of the patients who were randomized to medical therapy who crossed over to the intra-aortic balloon pump arm. In addition, in each arm there were around 10 patients who did not have coronary artery disease at all or non-significant coronary artery disease, which says that maybe they did not have a myocardial infarction and maybe the diagnosis of cardiogenic shock was erroneous. So at the end of the day, we're talking about 300 patients versus 300 patients. 30 of the patients crossed over from one arm to the other, and some did not undergo revascularizations, and some did not even have coronary artery disease. Now, again, the characteristics. We see that the median age was 70. We see that the patients had signs. Is there a pointer here? That's okay. Excuse me. Yeah, it's on the previous slide. Just 1 second. כן. אני יכול לראות את זה לשקופית הקודמת? Okay, that's fine. Okay, thank you. Okay, so we see that the median age is 70. We see that they had comorbidities. We see that around 30% of the patients had non-STEMI, in contradistinction to the shock trial. We see that many of the patients did have signs of hypoperfusion, and we see that the ejection fraction, the median ejection fraction was 35%. So these patients did not have profound heart failure. Here we see that around 95% of the patients did undergo primary PCA. That the use of an assist device was around 4% in the intra-aortic balloon pump and around 7.5% in the control arm, which showed a non-significant tendency. So there was more use of assist device in the control arm. But I think that the one thing that's pointed in the arrow, which goes unnoticed, is that mild hypothermia was used in around 35 to 40% of the cases. Now, I do not know of hypothermia as therapy for cardiogenic shock, which means that many of these patients may have been patients after resuscitation and not patients with true cardiogenic shock. And I want to remind you that the current guidelines stipulate that you do not give hypothermia to patients in cardiogenic shock. So I think this is a point to remember. The duration of catecholamine therapy was 3 days, and the time to hemodynamic stabilization was also 3 days. And these are the results of the Shock-II trial. It shows that actually in every parameter that was checked, comparing these two groups, there was no difference. This is the acute physiology score. This is GFR. By the way, the GFR was around 60 in these patients, which is not very reduced as would be expected in patients with cardiogenic shock over time. The serum lactate was also not different, and the CRP was also no difference. So actually you can say there's no difference between intra-aortic balloon pump and no intra-aortic balloon pump. And again, at 30-day, there's no difference in mortality. So we see the p-value of 0.92, which says that intra-aortic balloon pump did not help in this population. And when they took every subgroup that they checked, they see that actually there's no specific group that benefited from intra-aortic balloon pump. You take maybe no hypertension versus hypertension and so on. But again, there's no strong trend to show that one group benefited from intra-aortic balloon pump in this cohort, which would say that maybe intra-aortic balloon pump is useless in this population. In terms of safety, however, intra-aortic balloon pump proved to be very safe. Stroke in hospital was actually reduced in the intra-aortic balloon pump, not statistically significant. In terms of hemorrhagic complications, there was no difference. In terms of ischemic complications, in terms of sepsis, there was no difference. So you have a safe therapy, but it's quite useless based on the results, it seems. So what are the strengths of this study? First of all, it's the biggest study in cardiogenic shock ever performed, 600 patients. I remind you that the shock trial that we always quote from around 30 years ago, 25 years ago, had only 302 patients. And here they included patients over 32 months. The shock trial took around 5 years to enroll patients, and the follow-up was 99%. The limitations, first of all, we had no hemodynamic shock assessment, so we have no swan guns or a PA catheter to know that these patients actually were in shock. There was a 10% crossover to intra-aortic balloon pump, and the majority of the patients who did receive intra-aortic balloon pump in this study received that after the PCI was performed and not during the PCI, and maybe by that time the benefits of intra-aortic balloon pump are reduced. So, some more caveats. The mortality rate was expected to be around 56%. It was 40%. This is actually the best results ever in cardiogenic shock. The ejection fraction was 35%. Although these patients were supposed to be in shock, the median blood pressure, systolic blood pressure, was 90. So we're talking about patients with mild to moderate cardiogenic shock, not the patients with severe cardiogenic shock, or there was a representation of patients with mild to moderate cardiogenic shock. 86% did not require hemodynamic support during PCI. I know there are interventionalists in the audience here. I think it's very, very challenging to do a PCI in cardiogenic shock and acute MI when the patient has a blood pressure of 50 or 60 or 70. So it seems quite odd that they waited until after the PCI, and then in 86% only after that they put in the intra-aortic balloon pump. 1/3 of the patients had non-STEMI, and non-STEMI, there's a big spectrum, whereas STEMI is a bit more of a homogeneous cohort. And 40% of the patients had previous CPR and cardiac resuscitation. These are not the cardiogenic shock patients that we see on an everyday basis. So what are the clinical implications? That in mild to moderate cardiogenic shock, maybe catecholamine oppressors should be used rather than intra-aortic balloon pump. Maybe none of them should be used. But we have to remember, we showed that intra-aortic balloon pump is safe, whereas catecholamines increase myocardial oxygen demand. Maybe the implication is to start intra-aortic balloon pump not after PCI, you should start it before PCI, and again consider the severity of cardiogenic shock and reserve it only for patients with severe cardiogenic shock and not those with an equivocal diagnosis of cardiogenic shock. This study shows that there's actually not too much of a risk using intra-aortic balloon pump, and maybe the use of intra-aortic balloon pump may offer us an opportunity to do complete revascularization, which is a class 1 indication, whereas if you have an unstable patient, it's difficult to continue doing a complete revascularization during a primary PCI. Now, this is a busy slide, but I want just to emphasize, hammer in one point. During the sessions this morning about acute heart failure, we talked about inotropes, we talked about different therapies, and any device you talk about, there is no therapy for acute heart failure which has been shown to improve mortality at 30 days. So why are we surprised that intra-aortic balloon pump did not do this? There's not one therapy that we use for acute heart failure or cardiogenic shock. And again, for cardiogenic shock, we always say, we quote, that this is the one treatment that improves survival. I showed you that actually when you see the results, at 30 days, it did not improve survival at 30 days. It improved it at 6 months and 12 months. So actually, when we put everything in context, everything we do in cardiogenic shock or acute heart failure, nothing has been shown to improve mortality at 30 days thus far. Maybe it will change down the road, but till today, that's the situation. So what do we know about cardiogenic shock? It's a spectrum of disease with varying degrees of severity. Some, but not all, patients respond to intra-aortic balloon therapy. Some reasons for an absence of response may be hypovolemia or tachycardia. So you need to select the appropriate patients and identify if intra-aortic balloon pump has unloaded the heart. And in my mind, I think there's still a role for intra-aortic balloon pump It's used to stabilize systemic perfusion. It reduces LV stress and stroke work. It increments coronary perfusion. And as an interventional cardiologist, it helps me provide primary PCI in the most efficient manner. And that's why if we have a patient with cardiogenic shock, I put the intra-aortic balloon pump before doing the primary PCI, and then I think it improves survival. Thank you.